Good day. Today I am discussing acute asthma. Asthma is a chronic inflammatory disorder characterized by increased responsiveness of the airways to multiple stimuli. In susceptible individuals, the inflammation causes recurrent episodes of wheezing, breathlessness, chest tightness, and coughing, particularly at night or in the early morning. These episodes usually are associated with widespread and varying airflow obstruction. Although most acute attacks are reversible and improve spontaneously or within minutes to hours with treatment with symptom-free intervals in between, many asthmatic patients develop chronic airflow limitation. This impacts the diagnosis of, management of, and attempts to prevent acute exacerbations. Asthma is characterized by an abnormal accumulation of eosinophils, lymphocytes, mast cells, macrophages, dendritic cells, and myofibroblasts in airways. The pathophysiologic hallmark of asthma is a reduction in airway diameter caused by smooth muscle contraction, vascular congestion, bronchial wall edema, and thick secretions. These changes are reflected in pulmonary function changes, increased work of breathing, and abnormal distribution of pulmonary blood flow. The physiologic consequences of airflow obstruction are increases in airway resistance, decreased maximum expiratory flow rates, air trapping, increased airway pressure, barotrauma, adverse hemodynamic effects, ventilation perfusion imbalances, hypoxemia, hypercarbia, increased work of breathing, pulsus paradoxus, and respiratory muscle fatigue with ventilatory failure. Large and small airways contain plugs composed of mucus, serum proteins, inflammatory cells, and cellular debris. On a microscopic level, airways are infiltrated with eosinophils and mononuclear cells. Evidence of microvascular leakage, epithelial disruption, and vasodilation is frequently noted. The airway smooth muscle is hypertrophied and characterized by new vessel formation, an increased number of epithelial goblet cells, and deposition of interstitial collagen beneath the epithelium. Inflammation affects all bronchial pulmonary structures. Asthma is a continuum from acute bronchospasm to airway inflammation to permanent airway remodeling. The structural changes associated with airway remodeling, such as subbasement membrane thickening, subepithelial fibrosis, airway smooth muscle hypertrophy and hyperplasia, angiogenesis, and mucus gland hyperplasia and hypersecretion, are associated with non-reversible loss of lung function. Acute allergic bronchoconstriction results from immunoglobulin E-dependent release of mediators from mast cells. These mediators include histamine, leukotrienes, tryptase, and prostaglandins that directly contract airway smooth muscle. Bronchospasm induced by aspirin and other nonsteroidal anti-inflammatory drugs also involves mediator release from airway cells. Inflammation plays a key role in the pathophysiology of asthma regardless of disease severity. Inhaled antigens activate immunoglobulin E, mast cells, and T helper cells in the airway and induce the production of inflammatory mediators and cytokines. In turn, this initiates a cascade of reactions involving lymphocytes, mast cells, eosinophils, dendritic cells, macrophages, resident airway cells, and epithelial cells that perpetuate the inflammatory response with further release of chemokines, cytokines, cystenyl leukotrienes, and nitric oxide. The inflammatory process is multicellular, redundant, and self-amplifying. Numerous host and environmental factors, such as number and type of infections in childhood, frequent antibiotic use, Western lifestyle, and repeated exposures to allergens, may contribute to the development of allergic asthma. Viral respiratory infections are among the most common of the stimuli that invoke acute asthma exacerbation. Increased airway responsiveness secondary to infection may last anywhere from 2 to 8 weeks. Exercise is another common precipitant of acute asthma. Environmental conditions such as atmospheric pollutants and antigens noted in heavy industrial or densely populated urban areas, or increased indoor antigens such as mold, house dust mites, cockroaches, and animal dander are associated with higher incidence and severity of asthma. Occupational exposures such as metal salt, wood and vegetable dust, pharmaceuticals, industrial chemicals, plastics, biological enzymes, vapors, gases, and aerosols may stimulate an asthma attack. Agents such as aspirin, beta blockers, including topical beta blockers, nonsteroidal anti-inflammatory drugs, sulfating agents, tartrazine dyes, so basically everything with sulfas in them, and food additives and preservatives may trigger acute asthma. Exposure to cold air alone can induce acute bronchospasm. Endocrine factors such as changing levels of estradiol and progesterone during the normal menstrual cycle and pregnancy contribute to the level of airway reactivity. Emotional stress can also produce an asthma attack. The symptoms of asthma include dyspnea, wheezing, and cough. Many, but not all patients will relay the history of asthma upon presentation. Early in the attack, patients will complain of a sensation of chest constriction and cough. As the exacerbation progresses, wheezing becomes apparent, expiration becomes prolonged, and accessory muscle use may ensue. A thorough history can be helpful in guiding care for asthma exacerbations. Acute asthma exacerbations are categorized based on clinical features, with symptoms of cough, wheezing, shortness of breath, chest tightness, sputum production, and fever. So when it comes to cough, we look at whether it's perennial or seasonal. We look at the age at onset, and for wheezing, we check if it's continual or episodic. For shortness of breath, we check for the onset. For chest tightness, we look at duration. Sputum production is characterized by frequency. And for fever, we look at aggravating factors for the fever and the usual pattern of exacerbation and outcome. For disease history, we look at, apart from age of onset, we look at present management and medications, medication regimen adherence, history of chronic corticosteroid use or intermittent corticosteroid use, intensive care admissions, history of intubation, and best spirometry measures. Risk factors for death from asthma include a past history of severe exacerbation, more than 2 hospitalizations for asthma in the past year, more than 3 emergency room visits for asthma in the past year, more than 2 canisters per month of inhaled short-acting beta-2 agonists, difficulty perceiving airflow obstruction or its severity, low socioeconomic status or inner-city residents, illicit drug use, and psychiatric disease or medical comorbidities. Physical examination findings are variable. Patients presenting with severe asthma attacks may be in respiratory distress with rapid breathing and loud wheezing, whereas patients with mild exacerbation may present with only cough and expiratory wheezing. At times, wheezing may be audible without a stethoscope. Other conditions may present with wheezing and mimic asthma. So, those include acute heart failure, also known as cardiac asthma, in the sense of the wheezing that you get in acute heart failure, upper airway obstruction, multiple pulmonary emboli, aspiration of foreign body or gastric acid, tumors or disorders causing endobronchial obstruction, interstitial lung disease, and vocal cord dysfunction. The use of accessory muscles of inspiration indicates diaphragmatic fatigue. The appearance of paradoxical respiration, which is chest deflation and abdominal protrusion during inspiration, followed by chest expansion and abdominal deflation during expiration, or basically the posture that is taught to properly project the voice, is a sign of impending ventilatory failure. Alteration in the mental status, such as lethargy, exhaustion, agitation, or confusion, also heralds respiratory arrest. Directed physical examination reveals hyperresonance to percussion, decreased intensity of breath sounds, and prolongation of the expiratory phase, usually with wheezing. Although wheezing results from the movement of air through narrowed airways, the intensity of the wheeze may not correlate with the severity of airflow obstruction. The silent chest reflects very severe airflow obstruction, with air movement insufficient to promote an audible wheeze. A pulsus paradoxus, or a change in blood pressure during inspiration of more than 20 millimeters mercury, is also indicative of severe asthma, although it is not specific for asthma. Although tachycardia and tachypnea are usually seen with acute asthma, a normal heart rate, normal respiratory rate, and the absence of a pulsus paradoxus do not indicate complete relief of airway obstruction. Bedside spirometry provides a rapid, objective assessment of patients and guides therapy. The forced expiratory volume in 1 second, or FEV1, and the peak expiratory flow rate, or PEFR rate, directly measure the degree of large airway obstruction. Sequential measurements help assess severity and determine response to therapy. A flow volume loop can help distinguish asthma from vocal cord dysfunction. The latter is often treated as asthma, sometimes with repeated visits. Vocal cord dysfunction responds to the moisture, not the drug, in a nebulized treatment and fails meter dose inhaler outpatient therapy because moisture is not a part of that delivery system. If not documented, obtain a full spirometry assessment only in patients with frequent outpatient failures. Signs on physical examination and subjective symptoms do not necessarily correlate well with the severity of airflow obstruction, making objective measures valuable. Patient cooperation is essential for these tests to be reliable, limiting the value of spirometry in severe exacerbations or in non-cooperative patients. Pulse oximetry assesses oxygen saturation during treatment. Arterial blood gas measurement is not needed in most patients with mild to moderate asthma exacerbation, and it should be reserved for suspected hypoventilation with carbon dioxide retention and respiratory acidosis. With acute attacks, ventilation is stimulated, resulting in a decrease of partial pressure of arterial carbon dioxide or PaCO2. Therefore, a normal or slightly elevated PaCO2 of more than 42 millimeters mercury indicates extreme airway obstruction and fatigue and may herald the onset of acute ventilatory failure. Patients with impending respiratory failure almost always have clinical evidence of severe attacks or spirometry demonstrating a PEFR or FEV1 of less than 25% predicted. The use of capnography in acute asthma management is unclear. One small study reported good concordance between expired carbon dioxide levels measured by capnography and arterial carbon dioxide concentration, but another reported differences of up to 10 millimeters mercury or more between the two measurements. Radiography is indicated only if there's clinical suspicion of pneumothorax, pneumomediastinum, pneumonia, or other cause for symptoms such as acute heart failure or complications of asthma. For admitted asthma patients, less than one-third of patients have an abnormal chest radiograph. A CBC is not routinely needed and likely will show modest leukocytosis secondary to administration of beta-agonist therapy or corticosteroids. For the patients who are taking theophylline, we measure the serum level. Routine EKG is also unnecessary but may reveal right ventricular strain, abnormal P waves, or nonspecific ST and T wave abnormalities, which resolve with treatment. Older patients, especially those with coexisting heart disease, should have cardiac monitoring during treatment. The goal is rapid reversal of airflow obstruction by repetitive or continuous administration of inhaled beta-2 agonists, ensuring adequate oxygenation and relieving inflammation. The National Asthma Education and Prevention Program Expert Panel Emergency Treatment Algorithm is as follows. On initial assessment, we do a brief history, physical examination. We don't forget auscultation. We check for the use of accessory muscles, heart rate, respiratory rate, PEFR or FEV1, oxygen saturation, and other tests as indicated. For mild to moderate asthma, usually these are patients with an FEV1 or PEFR of greater than or equal to 40%. We give them oxygen to achieve an oxygen saturation of greater than or equal to 90%, an inhaled SABA or a short-acting beta-2 agonist to be specific, by nebulizer or meter dose inhaler plus valved holding chamber up to 3 doses in the first hour. And we give oral systemic corticosteroids if there's no immediate response or if the patient recently took oral systemic corticosteroids. For patients with severe asthma, also FEV1 or PFR of less than 40%, we give oxygen to achieve a oxygen saturation of greater than or equal to 90. We give a high-dose inhaled short-acting beta-2 agonist by meter dose inhaler plus ipratropium by nebulization every 20 minutes or continuously for 1 hour. Oral systemic corticosteroids is also indicated. For those with mild to moderate and severe asthma, we do a repeat assessment. We check symptoms, physical examination, PEFR, O2 sats, and other tests as needed. In moderate exacerbation, FEV1 or PEFR is between 40 and 69%. Predicted or personal best physical exam with moderate symptoms. We give an inhaled SABA every 60 minutes, oral systemic corticosteroids, and continue treatment for 1 to 3 hours provided there's improvement, and make a decision to admit in less than 4 hours. And for those with severe exacerbation, this is FEV1 or PEFR of less than 40% predicted or personal best. On physical exam, there are severe symptoms at rest, accessory muscle use, chest retractions. The history reveals a high-risk patient with no improvement after initial treatment. These patients can benefit from oxygen, nebulized SABA plus ipratropium hourly or continuous, oral systemic corticosteroids, and we consider adjunct therapies. For those with impending or actual respiratory arrest, we do intubation and mechanical ventilation with 100% oxygen, nebulized short-acting beta-2 agonists and ipratropium, IV corticosteroids, and we treat as in status asthmaticus. For patients with good response after treating exacerbation, be it moderate or severe, these usually are patients with an FEV1 or PEFR of greater than or equal to 70. The response is sustained 60 minutes after the last treatment with no distress and a normal physical exam. Those with incomplete response are those with an FEV1 or PEFR of 40 to 69% with mild to moderate symptoms. And those with a poor response are those with an FEV1 or PEFR of less than 40 with a PCO2 of greater than or equal to 42 millimeters mercury with severe symptoms, drowsiness, and confusion on physical examination. So when it comes to patients that have status asthmaticus, we will be discussing that later. Beta-adrenergic agonists with rapid onset are the preferred initial rescue medication for acute bronchospasm. Stimulation of beta-1 receptors increases rate and force of cardiac contraction and decreases small intestine motility and tone, whereas beta-2 adrenergic stimulation promotes bronchodilation, vasodilation, uterine relaxation, and skeletal muscle tremor. Beta-adrenergic drugs cause bronchodilation by stimulation of the enzyme adenylyl cyclase, which converts intracellular adenosine triphosphate into cyclic adenosine monophosphate. This action enhances the binding of intracellular calcium to cell membranes, reducing the myoplasmic calcium concentration, and results in relaxation of bronchial smooth muscle. Beta-adrenergic drugs also inhibit mediator release and promote mucociliary clearance. The most common side effect of beta-adrenergic drugs is skeletal muscle tremor. Patients may also experience nervousness, anxiety, insomnia, headache, hyperglycemia, palpitations, tachycardia, and hypertension. Clinical toxicity is rare and less common than under-treatment complications. Provoking dysrhythmias or myocardial ischemia is rare, especially in those without a prior history of coronary artery disease. The older catecholamine bronchodilators such as epinephrine are not beta-2 specific and have a short duration of action. Salbutamol is a 50-50 racemic mixture with equal amounts of left and right isomers. It is available in the hydrofluoroalkane formulation, which has increased its cost and effectiveness. The R isomer has great binding affinity for the beta-2 receptor and is responsible for bronchodilation. The S isomer has no bronchodilatory effect but has a long half-life. The isomer may be responsible for late paradoxical bronchospasm in some patients. Both racemic salbutamol and levosalbutamol can be given as intermittent or continuous nebulizations. Levosalbutamol costs 5 to 25 times more than salbutamol, and it has no clear advantage over salbutamol regarding symptom change, admission, or tachycardia. Aerosol therapy with beta-2 adrenergic drugs produces excellent bronchodilation and is favored over oral and parenteral routes. The aerosol route achieves topical administration of a relatively small dose of drug, thereby producing local effects with minimum systemic absorption and fewer side effects. Aerosol delivery occurs with a metered dose inhaler coupled to a spacing device or with a compressor-driven nebulizer. A spacing device attached to the inhaler improves drug deposition. When optimally used, metered dose inhaler therapy delivers the most drug to target airways, better than nebulized therapy. Even with optimum technique, a maximum of 15% of the drug dose is retained in the lungs, regardless of the aerosol method used. So when it comes to beta-adrenergic, anticholinergic, and steroid dosages of drugs for asthma, for the inhaled beta-2 agonists, we look at salbutamol. It's available in nebulizer solutions. The dose is usually 2.5 to 5 milligrams every 20 minutes for 3 doses, then 2.5 to 10 milligrams every 1 to 4 hours as needed, or 10 to 15 milligrams per hour as continuous nebulization. Only selective beta-2 agonists are recommended. For optimal therapy, we dilute aerosols to minimum of 3 ml at a gas flow of 6 to 8 liters per minute in order to ensure that delivery is maximized. We use large volume nebulizers for continuous administration. It may be mixed with ipratropium nebulizer solution. Meter dose inhalers are usually at 90 micrograms per puff. You do 48 puffs every 20 minutes up to 4 hours, then every 1 to 4 hours as needed. In mild to moderate exacerbations, a metered dose inhaler plus valve holding chamber is as effective as nebulized therapy with appropriate administration technique and coaching by trained personnel. There are also systemic injected beta-2 agonists such as epinephrine at a dilution of 1:1000 or 1 milligram per ml. It's given at 0.3 to 0.5 milligram every 20 minutes for 3 doses subcutaneously. There's no proven advantage of systemic therapy over aerosol. Terbutaline is given at 1 milligram per ml at 0.25 milligram every 20 minutes for 3 doses subcutaneously. Anticholinergics or combination drugs include ipratropium bromide. The nebulizer solution is 0.25 milligram per ml. You give 0.5 milligram every 20 minutes for 3 doses, then as needed. You can mix it in the same nebulizer as salbutamol, and as a result, there are often combination drugs of salbutamol and ipratropium. It should not be used as first-line therapy, but should be added to SABA therapy for severe exacerbations. The addition of ipratropium has not been shown to provide further benefit once the patient is hospitalized. The metered dose inhaler is at 18 micrograms per puff. The patient takes 8 puffs every 20 minutes as needed up to 3 hours. It should be used with a valved holding chamber and face mask for children who are younger than 4 years old. Studies have examined ipratropium bromide meter dose inhaler for up to 3 hours. So ipratropium with salbutamol is in a nebulizer solution with each 3 ml vial containing 0.5 milligrams of ipratropium and 2.5 milligrams of albuterol or salbutamol. 3 ml every 20 minutes for 3 doses and then as needed. It may be used for up to 3 hours in the initial management of severe exacerbations. The addition of ipratropium, again, has not been shown to provide further benefit once the patient is hospitalized. Meter dose inhalers of salbutamol and ipratropium as a combination. In each puff, there's 18 micrograms of ipratropium and 90 micrograms of salbutamol. You also take it at 8 puffs every 20 minutes as needed for up to 3 hours. Systemic corticosteroids used in asthma include prednisone. For inpatients oral burst, you use a 40 to 80 milligram per day in 1 or 2 divided doses kind of strategy until PFR reaches 70% of predicted or personal best. For outpatients oral burst, we use 40 to 60 milligrams in single or 2 divided doses for 5 to 10 days. Methylprednisolone is given intravenously at 1 milligram per kilogram every 4 to 6 hours. For outpatients, a single IM dose of 150 milligrams depot methylprednisolone may be used. And prednisolone is given at 1 to 2 milligrams per kilogram per day for 5 to 10 days and may be divided twice daily. It's more frequently used over prednisone in children due to increased palatability of available liquid formulations. Aerosol treatments may be administered every 15 to 20 minutes or on a continuous basis. Subcutaneous epinephrine and terbutaline are options for patients unable to coordinate aerosolized or meter dose inhaler treatments seen often in severe airflow limited states. Intravenous beta agonist infusions offer no advantage over aerosolized or metered-dose inhaler-delivered agents and carry increased risk. Salmeterol, sinafoate, and formoterol are beta-2 adrenoreceptor agonists that bind with greater affinity to the beta-2 receptor site than salbutamol. They are indicated for twice-daily maintenance therapy. Neither drug should be used for acute asthma exacerbations. Bronchodilator effects last at least 12 hours, and tachyphylaxis has not been reported with long-term use. Long-acting beta-2 adrenoreceptor agonists are an effective treatment for long-term control of asthma, especially in conjunction with inhaled corticosteroids. Short-acting beta-2 adrenoreceptor agonists are used for infrequent or breakthrough symptoms that occur despite the use of long-acting beta-2 adrenoreceptor agonists. Corticosteroids are a cornerstone of asthma treatment. Steroids produce beneficial effects by restoring beta-adrenergic responsiveness and reducing inflammation. The peak anti-inflammatory effect occurs at least 4 to 8 hours after IV or per orum administration, but early use is wise to enhance care quickly, and corticosteroids given within 1 hour of arrival in the emergency room reduce the need for hospitalization. Although there's disagreement over the optimal dose in acute asthma, an initial dose of per orum prednisolone at 40 to 60 milligrams or IV methylprednisolone of 1 milligram per kilogram is sufficient, and higher dose corticosteroid therapy offers no advantage. Admitted patients should receive additional daily corticosteroids until subjective and objective improvements are achieved. Patients who are being discharged home with an FEV1 or PEF of less than 70% predicted after aggressive emergency room treatment should be prescribed a 5 to 10 day non-tapering course of prednisone at 40 to 60 milligrams per day in a single daily dose or its equivalent, or a 2 day course of oral dexamethasone at 16 milligrams per day in a single daily dose. A single dose of depot methylprednisolone, 150 milligrams IM, is another option if compliance is a concern. Current recommendations favor inhaled corticosteroids for all patients with mild persistent asthma or more severe asthma. This means discharging patients with mild persistent or more severe asthma on maintenance inhaled corticosteroids in addition to any systemic bursts. Inhaled corticosteroid options are beclomethasone, 80 to 240 micrograms per day, budesonide, 180 to 600 micrograms per day, flunisolide 500 to 1000 micrograms per day, fluticasone 88 to 264 micrograms per day, mometasone at 200 micrograms per day, and triamcinolone acetonide at 300 to 750 micrograms per day. The effects of anticholinergics used in combination with beta-adrenergic agents are additive. Anticholinergics affect large central airways, whereas beta-adrenergic drugs dilate smaller airways. Anticholinergic drugs competitively antagonize acetylcholine at the postganglionic junction between the parasympathetic nerve terminal and the effector cell. This process blocks the bronchoconstriction induced by vagal cholinergic-mediated innervation to the larger central airways. In addition, anticholinergics reduce concentrations of cyclic guanosine monophosphate in airway smooth muscle, further promoting bronchodilation. The anticholinergic commonly used is inhaled ipratropium bromide. It is available as a nebulized solution and a metered-dose inhaler or in combination with salbutamol. We use an aerosolized ipratropium bromide solution, 0.5 milligrams, in patients with moderate to severe exacerbation. Adding multiple doses of ipratropium bromide to a short-acting selective beta agonist may improve bronchodilation and decrease the need for hospitalization among severely obstructed asthmatics, although this benefit is not universal. Potential side effects with anticholinergics include dry mouth, thirst, and difficulty swallowing. Less commonly, tachycardia, restlessness, irritability, confusion, difficulty in micturition, ileus, blurring of vision, or an increase in intraocular pressure can occur. Long-acting anticholinergic agents have no role in acute care. Status asthmaticus is also known as acute severe asthma, and it is an acute severe asthma attack that does not improve with usual doses of inhaled bronchodilators and steroids. Signs and symptoms include hypoxemia, tachypnea, tachycardia, accessory muscle use, and wheezing. Wheezing may be absent when airflow is severely reduced. Rapid treatment is the key to preventing cardiopulmonary arrest. In addition to usual and ongoing bronchodilators coupled with early steroids, other treatment adjuncts exist. IV magnesium sulfate is indicated in the management of acute, very severe asthma with an FEV1 of less than 25% predicted. The magnesium dose is 1 to 2 grams IV over 30 minutes. Nebulized magnesium is effective and may also improve pulmonary function in severe asthma when it follows aggressive beta agonist and steroid therapy. Dosing regimens may vary. One is 95 milligrams of nebulized magnesium sulfate in 4 divided doses 20 minutes apart, and another is 384 milligrams of nebulized magnesium sulfate in sterile water. When using magnesium in any form, we monitor blood pressure and deep tendon reflexes during administration because hypotension or neuromuscular blockade may occur, although this is rare in the doses recommended. Non-invasive positive pressure ventilation improves airflow and respiration compared with usual care, and despite little research, it is commonly used in clinical practice for acute life-threatening asthma. Non-invasive positive pressure ventilation decreases the need for intubation, results in clinical improvement, and decreases the need for hospitalization. We do not institute it if intubation is indicated or in patients with suspected pneumothorax. Ketamine inhibits reuptake of noradrenaline and thus increases circulating catecholamines, aiding some with severe asthma. An IV bolus dose of 0.2 mg per kilogram followed by an infusion of 0.5 mg per kilogram per hour is sometimes used, and higher doses are validated. If intubation is needed, ketamine is a good agent to aid during the procedure and after mechanical ventilation starts. Although epinephrine is standard treatment for anaphylactic asthma, it is overlooked as an adjunct to treat status asthmaticus. It can be given subcutaneously or IM 0.5 mg in adults in refractory situations. If the patient manifests progressive hypercarbia or acidosis or becomes exhausted or confused, intubation and mechanical ventilation are necessary to prevent respiratory arrest. Mechanical ventilation does not relieve the airflow obstruction. It merely eliminates the work of breathing and enables the patient to rest while airflow obstruction is resolved. The potential complications of mechanical ventilation in asthmatic patients include extremely high peak airway pressures with subsequent barotrauma and hemodynamic impairment. Mucus plugging is frequent, leading to increased airway resistance, atelectasis, and pulmonary infection. Due to the severity of airflow obstruction during the early phases of treatment, the tidal volume may be larger than the return volume, leading to air trapping and increased residual volume, which is intrinsic positive and expiratory pressure. Using rapid inspiratory flow rates at a reduced respiratory frequency of 12 to 14 breaths per minute and allowing adequate time for the expiratory phase can mitigate these effects. It is also reasonable to target adequate arterial oxygen saturation at greater than or equal to 90% without concern for normalizing the hypercarbic acidosis. This approach is called controlled mechanical hypoventilation or permissive hypoventilation. Ventilation of asthmatic patients requires sedation. Neuromuscular blocking agents may be required, but extended use may cause post-extubation muscle weakness. Agents of uncertain or no benefit in status asthmaticus include Heliox, which is a mixture of 80% helium and 20% oxygen, methylxanthines such as aminophylline and theophylline. There are also other agents such as mast cell modifiers such as cromolyn and nidocromil, which exert their anti-inflammatory action by blockage of chlorine channels, modulating mast cell mediator release and eosinophil recruitment. These agents also inhibit early and late responses to allergen challenge and exercise. Neither is indicated for the treatment of acute bronchospasm. Leukotrienes are potent pro-inflammatory mediators that contract airway smooth muscle, increase microvascular permeability, stimulate mucus secretion, decrease mucociliary clearance, and recruit eosinophils into the airway. Several leukotriene modifiers, namely montelukast, zafirlukast, and ziluton, are available as oral tablets for the treatment of asthma. They improve lung function, diminish symptoms, and diminish the need for short-acting beta-2 agonists. They may be used as an alternative to low-dose inhaled corticosteroid therapy in mild persistent asthmatics and as steroid-sparing agents with inhaled corticosteroids in moderate persistent asthmatics. Despite one trial with adjuvant IV montelukast for acute asthma, there is no indication for the use of any of the leukotriene modifiers in the emergency room. So, before discharging a patient with asthma, specifically status asthmaticus, when we give them inhaled medication such as a metered dose inhaler with valved holding chamber or a nebulizer, we teach the patient the purpose of this medication. Same with short-acting beta-2 agonists, we have to check the technique. For corticosteroids in metered dose inhalers, we emphasize the importance of using a spacing device or holding chamber. And for peak flow meters, we usually measure at the morning and evening peak expiratory flow and record a best of 3 tries each time. So we also need to ask the patients to keep a peak flow diary. And that's it. Thank you.